Hello everyone, welcome to our videos about disc herniation. So today, we are going to delve into its causes, epidemiology, clinical examination, diagnostic modalities, treatment, management, exercises, and differential diagnosis.
An intervertebral disc is composed of annulus fibrosus. The annulus fibrosus, dense collagenous ring encirculating the nucleus pulposus, and is often divided into the inner and outer annulus. Disc herniation occurs when part or all the nucleus pulposus protrudes through the annulus fibrosus. The most common cause of disc herniation is a degenerative process in which, as human age, the nucleus pulposus become less hydrated and weakens. Therefore, vertebral height approximates and increases further compression on the disc. Progressive disc herniation can occur as a result of this process, which can lead to symptoms. The second most common cause of disc herniation is trauma, often due to lifting or twisting. Other causes include connective tissue disorders and congenital disorders such as short pedicles. Disc herniation is most common in the lumbar spine, followed by the cervical spine. The lumbar and cervical spine experience a great risk of disc herniation due to the biomechanical forces on the flexible part of the spine. The thoracic spine has a low rate of disc herniation. The pathophysiology of herniated disc is believed to be a combination of the mechanical compression of the nerve by the bulging nucleus pulposus and the local increase in inflammatory chemokines. A herniation is more likely to occur posterolateral aspect of the lumbar spine, where the annulus fibrosus is thinner and lacks structural support from the anterior or posterior longitudinal ligaments. The nerve root is more likely to be compressed by a posterolateral herniation. A large midline disc herniation could result in spinal cord compression and clinical myelopathy. The prevalence is most significant among 30 to 50-year-old patients. The patients between 25 to 55 years old have an approximately 95% chance of herniated discs occurring either at L4, L5 or L5S1. Pain can be described as sharp or burning. There is often radiation of the pain in the distribution of the compressed nerve root. The part of the nerve root may experience numbness and tingling as well as decreased sensation. The presence of weakness or feeling of instability during ambulation may be endorsed in more severe cases. A thorough case history and neurological examination can aid in identifying the level of disc compression. The examination consisted of testing reflexes, muscle strength, walking ability, and the ability of perceived light touching, pinpricks, or vibration. In addition to the pain being exacerbated by straining, coughing, and sneezing. The straight leg raise test is a neurological maneuver that is performed while examining a patient who is experiencing lower back pain. When the test reproduces the patient's symptoms, pain and paresthesia at an angle below 45 to 60 degrees, and when the pain radiates below the knee, it indicates a positive test. Patients with low back pain frequently describe problems with walking and usually walk slower. Patients with L5 nerve root compression will present with a weakness in hip abduction, knee flexion, foot dorsiflexion, big toe dorsiflexion, foot inversion, and eversion. Patients with S1 nerve root compression will present with a weakness on foot plantar flexion, hip extension, and flexion of the knee. Weakness in plantar flexion causes an inability to tiptoe walk. MRI is the most effective and sensitive way to visualize a herniated disc. Surgeons and other providers can use MRI findings to plan procedural care if it is necessary. Treatment. This approach is the initial management of choice in patients presenting with symptoms of acute lumbar disc herniation. Primary care practitioners can initiate treatment with a short course of rest, appropriate patient education, and exercise recommendation. Specific exercise will help strengthening your lower back and abdominal muscles. However, physical therapy is not recommended before 3 weeks of the onset of symptoms. If symptoms persist beyond 6 weeks, transforaminal or interlaminar epidural steroid injection may be considered for short-term pain relief in some patients with radiculopathy. As always, surgical treatment is the final resort. Yet, discectomy and laminectomy performed to treat radiculopathy caused by lumbar disc herniation. What other factors could be causing the back pain? Mechanical back pain, muscle strain, osteophytes, spondylolisthesis, degenerative spinal stenosis, cauda eguina syndrome, epidural abscess, epidural hematoma, diabetic amyotrophy, metastasis, ankylosing spondylitis, and synovial cyst.
Thank you so much for watching and subscribing, and hit that subscribe button to join our growing community. Don't forget to like this video, share it with your friends, and leave a comment below letting me know what you think. Alright, that's all for now, but I'll see you in the next video.